So I just wanted to introduce ourselves to you so you know who we are, and you probably all know that we are ArizOTA. We are a member organization and we're all volunteers. We do not have any legislative function, or we're not able, of course, to mandate anything. We're not the licensing board. We are just practitioners like you all, and we volunteer because we feel it's important that we are working for our profession, making progress and supporting each other. And this town hall really started as an initiative from everyone in ArizOTA. We have all our board members, we have our fabulous legislative committee, special interests, section chairs, and also our student interns. So everyone has really been involved in this and done a lot of work. And I'm very excited about that. So we can now go to the next slide and let's begin.
Is Wade unmuted?
I think this is
Okay.
Wade, yeah?
Yeah, I think I'm here. Just a second. So obviously I'm the noob when it comes to Zoom, but so the executive order, and the link will be in the slide. It's also on the resources page, but the executive order not only permitted occupational therapists to utilize telehealth in order to serve clients, but it also mandated parity, meaning that the insurance companies must pay at the same rate as if it was in the clinic. So our HB 2536, in contrast, really permitted the practice of occupational therapy via telehealth, but it did not mandate parity. HB 2536 or something like it will likely have to come up again in the next legislative session. We were quite successful with that. It was actually on the consent agenda for the Senate prior to, really the drastic alteration of the legislative calendar. Our next real goal, on the ultimate goal, is not just recognition for occupational therapists in telehealth, but also to mandate that parity. And I apologize, I was supposed to introduce myself, but I'm Wade McTowell. I'm the Director of Therapy Services here at Summit Healthcare in Show, Arizona. I have been a director or more. I've had as many as 187 employees. I've been researching legislation, reimbursement, those kind of things for over 25 years. And this is my responsibility in my current role. I also have an MBA from the University of Utah. So apologize, I missed that. And Vida?
Oh, Vida is muted. We have to unmute Vida.
Sorry about that. My name is Vida Colmer, and I am an occupational therapist. I've been an occupational therapist since 1996, so have seen a lot of changes in healthcare, but never to this extent. And I'm also an Arizona licensed attorney, and I'm the in-house counsel and chief compliance officer at WebPT. So I do know a lot about HIPAA requirements when it comes to software. And in the non-pandemic times, you usually, as a covered entity, which all of you are and which we are under HIPAA, have to be very thoughtful and exercise diligence in vetting our software to make sure that it does have reasonable and appropriate security requirements to protect confidentiality, integrity, and availability of PHI. And that can take time, and it also costs money. The software programs like Zoom and Skype for Business cost money when you want a HIPAA compliant solution. And we are all required to sign business associate agreements that meet the regulatory requirements, and those vendors will charge additional money. So I think I've heard that Zoom could be about $200 a month if you want to sign a BAA, because the vendor has to implement all these security requirements for that particular account. However, the pandemic came on quickly, and all of us weren't delivering services using telehealth, and the whole country had to pivot to this new model that we were all, toes in the water adopting. And the Office for Civil Rights, which is the enforcement agency for HIPAA, issued a press release this month that said that they would exercise their enforcement discretion when it comes to covered entities adopting telehealth to provide services to their patients. And so this does not mean a waiver. They're not waiving your requirements to make sure you continue to protect that patient's information and continue to exercise, reasonable security measures. Like you can't use TikTok or Facebook Live to provide telehealth. And you still cannot go to a coffee shop. And I mean, none of us can go to a coffee shop right now anyway, but you have to be in a private place and still make sure that you're implementing security and privacy within your physical environment. But OCR will not impose penalties if you are using a free version of one of the recommended platforms right now during the crisis. And they list out those platforms, and they are Skype for Business and UpDocs and Doxy.me, and I'm sorry,
Zoom,
Google Hangouts, VC, and Zoom. Now that's just during the crisis. Once the crisis is over, and if you want to still continue to provide telehealth services, which is in our future as OT providers, you have to upgrade to a HIPAA compliant version. So it's probably better to make sure before you select a platform that you at least look on their website and determine if that is an option at a later date to be able to upgrade and sign that BAA. And then once the crisis is over, all of those HIPAA compliance requirements are going to kick in. And if you're not making sure you're using a secure solution, you could be subject to fines. So just keep that in mind. And there is a link to the press release, the OCR press release, if you have any questions. So next slide, please. When it comes to telehealth, there are other considerations to think about in addition to the privacy and security requirements. When you're delivering live telehealth that's not being recorded, let's say that you're treating or you're assessing a pediatric patient and you're using a standardized assessment like the BOT, that's probably not infringing on any owner's copyright or proprietary rights to that test materials, because you're not recording that session. You're using it for the purpose it was intended to be used for, which is to deliver assessments, and you aren't at risk for copyright issues. However, if you decide at a later date you want to market your telehealth services and you're going to record portions of the session and strip out patient information, you also have to be cognizant that you want to strip out any copyrighted materials. So any logos that have TM or R next to them. A lot of people don't realize CPT codes are copyrighted and owned by the AMA, and they are very rigorous in protecting their copyrights, and you always have to have that little R in the bubble next to it. And I would just recommend being cautious about displaying those codes if you have a website. And in addition to that, all of those standardized tests that are primarily used in pediatrics, those are not necessarily copyrighted, but they are all proprietary. So the test owner they own those. They are very protective of those materials. Anybody that's worked in a school system knows you're really not supposed to photocopy those test booklets and reuse them. So just be cautious about displaying those in any of your recorded materials or any company logos. In terms of licensure comes into play when it comes to the state requirements, the Arizona board requirements, and also your commercial payer policies. If you are treating a patient using telehealth, you have to be licensed in the state where the patient is sitting. So you can physically be anywhere in the country and not be licensed in that state, but if your patient's in Arizona, you have to have an Arizona license, Arizona occupational therapy license in good standing. And then check your payer policies to make sure those align with the State Practice Act. And then sometimes Medicare does not always have the same licensure requirements. Right now, OTs are not licensed telehealth providers. We may be in the future. If Medicare's licensure requirements differ from Arizona's, if they're stronger or stricter in any way, you have to comply with Medicare because that's a federal it's a federal regulation, and federal regulations override state regulations. So that's something to keep in mind.
Vita, I have just a question to clarify that point, because I think some others might have the same question. So but you're talking about if you're providing therapy to a Medicare patient only, you're providing it to Blue Cross Blue Shield, that Medicare restriction is not a factor.
If that Blue Cross Blue Shield is not a Medicare Advantage or Medicare replacement program. So if it's a true commercial policy, then the Medicare requirements do not apply.
Okay.
And then in terms of supervision, the supervision requirements in our Practice Act still apply even when it comes to telehealth. So if you are an occupational therapist supervising a CODA, the Practice Act requires you to, I'm even going to pull it up right now so I can look at the exact language. It requires you to supervise, first of all, to implement supervision requirements that meet the needs of that CODA skill level and the needs of the patient, to make sure that you as the licensed therapist are providing adequate supervision. So if the patient has very complex needs, you may have to provide more supervision, or if the CODA doesn't have a lot of experience, you may have to meet with them regularly. The supervision requirements are face-to-face contact between the licensed therapist and the CODA, but not necessarily, you don't have to have the patient with you during the supervision requirement. So it's just a face-to-face contact. Now the challenge is the Practice Act was written when there wasn't a pandemic going on, and we are not necessarily prohibited from face-to-face contact because OT is an essential service, but let's say that you don't feel comfortable meeting face-to-face. So we don't know how the board is going to treat this. I would strongly recommend emailing the board if you have questions. In the meantime, I would say that we probably still have to meet face-to-face because it doesn't allow for the use of technology. But hopefully, if enough of us email the board with questions, they'll provide some clarification. And then another legal consideration when it comes to telehealth is that you have to provide informed consent. And that's a little bit different than when we have a patient that we see in person. There's different considerations that we have to review with the patient, not for every visit, but at the beginning of the visit, and making sure. Now our Practice Act, because this was an executive order, our Practice Act doesn't clarify whether we actually have to have a signed hard copy of the informed consent. If you decide to do that, probably be best practice to have a copy of that on hand. If you could move to the next slide. So informed consent is going over, with the patient that they're going to receive telehealth services and what that entails. If, live interactive video with audio, or is it going to be audio only? And then explaining to the patient that they do have a right to refuse or discontinue those services. They have a right to refuse at the beginning, but they also have a right to request discontinuation of the services at any time. And that at that point, during the pandemic, you may decide to put the session on hold, and then resume later face to face. And then just describing the benefits of telehealth. In this situation, the benefits obviously are that the patient can continue critical therapy services without being exposed to risk of infection. But there's other benefits as well, like if they don't have consistent transportation, or if they live in a rural area, or they're very ill and it just takes a lot out of them to get out of the house. They have better access to health care through the use of telehealth. But there's also constraints because you won't be there, and so they may not get the same benefit from telehealth as in person for some types of services, or they may even struggle to use the technology. And then talking about the risks, like the privacy and security risks, that maybe somebody could overhear their session, or security issues with, hopefully not the software if you've done, your diligence later on, but there is still a risk. We live in an age where a lot of data breaches occur, and the patient should be aware of that. And then talking about what happens if the technology fails. What's the contingency plan? Are you going to give it a couple minutes and resume, or would you reschedule? And setting the expectations for the patient in advance, what is expected of them. They have to get the equipment set up. Maybe you're sending out email instructions and you need them to review those. And they should be in a quiet place with good lighting and reduced distractions, or wearing comfortable clothing. If it's a patient where you need them to have certain equipment in place, making sure they get that ready in advance. And I would say that if you have to have the patient's consent before you record any session. And so in the template, I did add a clause that said, if the patient wanted you to record the session, they have to tell you in advance, but you are not allowed to record that session without letting them know in advance. And also the consent includes, information about your compliance with applicable laws, such as the State Practice Act and HIPAA and state privacy laws, and the informed consent requirements.
Vita, before we move on, I had a couple of questions come across the chat about, well, the first one is, can a Zoom meeting with a COTA be face-to-face, or does it have to be? I think that's what you were saying, they have to contact the board to clarify.
Yeah, and unfortunately, when we were working through the change to the Arizona statute, the board was positioned to change the Practice Act to start to incorporate these types of changes, such as informed consent and face-to-face requirements. Can that be accomplished through a telephone or through Skype? But then the pandemic happened, so the Practice Act does not currently allow supervision using telephone or Skype or some type of other technology. So I would say that if you feel comfortable with social distancing, and if you have a face mask or a bandana that you can wear, and knowing you have to feel comfortable about this, you and the OT assistant then having that face-to-face meeting and strictly adhering to your Practice Act is probably your best bet. But we should all still email the board and ask them for clarification, and expect they may not be able to tell us because this is a statute and they don't have authority to change a statute.
There's two other questions. One is on regarding informed consent. Is informed consent recommended for each treatment session or just the initial teletherapy session? That's actually a really good question.
So informed consent is recommended at the beginning. So when you start the whole intervention, at the very first session, go over the informed consent requirements, and then ask them to sign off on the document if that's what you choose to do. You do not have to revisit those with the exception of recording. If you decide at any point during your intervention that you want to record that session, you have to get informed consent at that point. And I would say even take the extra step of having them sign off or send you something in writing so that you have proof. It could even be as simple as an email, just something that shows that you have proof that they authorized you to record the session.
So maybe even a date range from this, kind of like we do when we go to the doctor and we give them permission to send our records, like with a date range.
Yeah.
So, okay, a couple more. Zoom also has a Zoom healthcare option, so she's letting us know that. Just to clarify, for the time of the pandemic, the standard Zoom is okay to use. I think the answer is that.
Yes, that is correct, because the Zoom healthcare option is expensive, but the Office for Civil Rights said that they will not exercise their enforcement discretion, which means they're not going to investigate you and fine you for using the free version of Zoom, which is not HIPAA compliant during the pandemic.
And then what is the best way to track or to know when the pandemic ends and the HIPAA requirements resume?
Well, we will update it on the website, and the governor will release communication that all of his emergency orders will no longer be in effect.
Okay. I think that's the last question. Wait, one more. You can use Jitsi Meet. There is no limited number of participants. So it sounds like that might be another one. Okay.
All right.
You ready for the next slide?
Yep.
Okay. Was this one Wade, or were you going to do this one?
This one is you, Wade.
Wade muted himself. Wade's not a Zoom expert. Everything else, he's like a wealth of knowledge. Let's see.
Okay. Just to be clear, if there was a question, I am not the Zoom expert.
So wait, can I ask one more question before you start? Because I think it's what Vita was just talking about. If I'm doing evaluation and need the parent to fill out the SPM or similar, what is the best way to proceed?
In that case, if you, and I'm not familiar with that document, I would recommend
SPM mean, Margaret? I'm assuming it's a parental consent for a child. Oh, something about parent of a minor.
So
sensory processing measure.
Oh, okay. Oh. It was close.
Those are tough because there's no way to have a fillable form. You may have to send it to them in an email if you have scanning, and then they could photograph it and send it back to you.
So Vita, sorry to interrupt you. So on the comments, sorry everyone, Diana Henry can respond. I think she like wrote the SPM. So Heidi, can you unmute Diana Henry? Are you able to?
Yeah, hi, thank you. Yes, I did want to find out about using the SPM, and I am a co-author for it. So I did contact the president and all of that. And anyway, it is available online. It is on a HIPAA compliant platform. It's always been that way. But I asked him specifically for telehealth, and he sent me a document, which I'm happy to share with you, which basically explains that if you are using the SPM, which is standardized, it hasn't been standardized in telehealth, even though it's a checklist that raters fill out. It has not been standardized for telehealth. So you just have to, the same, I think, as that informed consent, would let the people know who are going to be using it that that's the key. So I'm happy to share that with you if you would like.
Yeah, that'd be great. If you could share it on the chat, or you can email the direct office and we can share it on our website.
So yeah, it's a document. I don't know how to do it on the chat. It's an actual doc.
Oh God, yeah, just email office@arizota.org and we can put it on our website.
Okay, will do.
Thank you, Diana.
Thank you. Yeah.
Yes, thank you, Diana. Appreciate that.
You want to? Do we want to? Just before Wade gets started, somebody's asking if they're allowed to use copyrights. And DocuSign is a fillable form. Yeah, I use that.
In terms of using copyrights, I think what you mean is anything with a copyrighted logo. And I don't think it'll be a problem if you're using something with copyright logo in an unrecorded session as part of your treatment, because it's not going to be archived anywhere. And there are certain exclusions or exceptions to copyright called fair use exceptions when you're just using them in a limited way. So the only time it will really be a problem is if you decide you want to market your telehealth and you scrub your videos of patients and you have copyrighted or proprietary information in those videos. That's the only time where you could risk copyright infringement. So I would just be very cautious about that and very cautious about displaying those CPT codes.
Another question along the same lines is it all right to disseminate that through email when typically we aren't supposed to photocopy the form?
I mean, I know Diane Henry's on the call, so I'll be very cautious about saying this, and especially being a web PT, you know, we were cautious about not displaying that proprietary standardized test booklets in any of our software. But this is a very extreme circumstance that none of us would have predicted. It's a pandemic. So I would say for this purpose, it is probably safe to say that you could do that for the purposes of treating your patient, not for any other purpose, but you're still, the test booklets were intended, those questionnaires were intended for patient or client use. And if that's what you're doing, only you're using email because of the social distancing and other requirements, then I think you're fine for now. I would not recommend that in the future.
And then I think the last one we go on, Barbara has asked a couple of times, can we use DocuSign for informed consent?
Yes.
Okay, I think you're up, Wade. Really this time, for real.
Oh, no problem at all. So this is our organization's list of personally identifiable information, a component of protected health information. And I wanted to include this because even though I remember when HIPAA was new, when HIPAA was a proposal, so it's not that I don't know these things, but I almost botched on one of these today. You notice that ours, I think the fourth bullet down, includes email addresses. And I was about to circumvent that one. So my intention in including this list is that if you're going to bend these rules as allowed by the executive order and by CMS direction, just be sure you are conscious and cognizant and even tracking what it is that you are doing so that you can undo it or mitigate the risk when this crisis is declared over, and that way you can still protect yourself and your organization and your firm. So reimbursement here, we've really dug into this as well. For our organization, I have 30 therapists, OT, PT, and speech. This is a big deal to us, as it is to all of you. Medicare Part B is only covering the e-visits at this time. And there's a fact sheet that we have in the resources about these e-visits. They are very specific. So be sure you understand what those are. So some of the answers that we came up with from some of these private payers, some of their websites say they don't even cover it, even though the governor's executive order says that they must. One of the things that you may find helpful as you really dig into this is look at those specific payer coverages. Be sure you understand what the billing codes and modifiers which may be required are. There are several possibilities, but each payer may have very different requirements for their code. Maybe it's a 95 modifier, maybe it's a GT modifier. I've seen some things like CD modifiers, things like that, that could be required. Make sure you know what it is. One of the suggestions from Rick Gowenda on podcast that I listened to or watched actually earlier in the week is, and my staff found this to be very helpful, is when you contact the insurance company, ask a very specific question. Can you direct me to the URL that covers occupational therapy for telehealth? I'll tell you, my staff got a negative answer. They couldn't actually do that. So this is still nebulous. We'll do our very best to update all of you as we're able and as the information comes in, as we have some claims experience as well. Let's see, reimbursement for evaluation. Some of that varies from payer to payer. Be sure you understand for the payer that you're dealing with. And be sure to document the distance site and the originating site in your treatment note. Types of telehealth coverage. We also found some varied. Some included audio, some included just synchronous, that is live audio and video. I've seen some other stuff for physicians that can include email and things like that for an electronic visit that way.
Wade, if I can jump in and just talk quickly about Medicare and telehealth. Right, the e-visits under Part B are not telehealth. There are special codes. They're considered case management codes. On March 30th, the Center for Medicare and Medicaid Services released an interim final rule to facilitate telehealth during the public health emergency, and they did not add OT, PT, or speech. They added the codes that we use. They did not add us. So I don't know if they intended for physicians to bill those codes and be reimbursed, but we are not authorized telehealth providers under Medicare Part B. So if you do try to bill, you're probably going to have your claims denied. So what I am asking everyone on this call today is to go to our website and download our advocacy template and send that to CMS, asking them to add us as telehealth providers. The reimbursement is significantly more than those e-visits. Those e-visit codes are about $34 a visit. They're very limited. Telehealth, Medicare is the same as in-person essentially. And so please take that 5 minutes and send that. We hope that we can make this change as soon as possible, but your advocacy efforts are needed. And that's all I had to say about that.
Yeah, thank you, Vita. That's a good reminder, because earlier this week, AOTA, APTA, and ASHA have petitioned CMS to recognize therapists as telehealth providers. The document that came out that Vita reference was 221 pages, and although it was a little bit circular, they were pretty clear that we were not allowed to bill full visits, regular codes for our services in telehealth.
Everybody's asking about that template, the advocacy template that you referenced. We're going to put that on the website, right?
Yeah. Ashley, is that template on the website?
I think she might be muted, Heidi. Let's see.
Hello, yes, it is on our website in a couple of different places, but we'll also send out an email with that information. But at the end of the presentation, we'll go over, but there's a new web page that we have with all the resources we've talked about. And we'll discuss where you can find all of that. But yes, the answer is yes.
So here's a list of some of the items that we came up with for some popular telehealth platforms. I know there's been others mentioned in the chat. Just keep in mind that the distinction is public facing versus one-to-one end-to-end encrypted is really the key element here. And so the HIPAA compliant are what Vita talked about earlier, where these firms would be willing for a fee to sign a business associate agreement with you and be fully compliant with HIPAA after the conclusion of this pandemic emergency. The not HIPAA compliant list is again those that are useful now, but only now, and they will end. The not recommended are the ones that are more public facing, like Facebook Live. You know, some firms will post on Facebook Live for a broad audience, but that's not appropriate for services to clients.
And if you don't mind me just reiterating that, you know, this is only the security of the platform. You as the provider have additional security and privacy requirements, and those are not alleviated with the OCR rule. So back to what I said before, you can't be in a public place. You have to be in a private place where other people can't hear you, and you're still protecting the privacy of the patient, and be very careful about recording. I would always advise against recording unless the patient wants you to, because that's just more PHI that you're going to have to protect later. And so just being cognizant that it's not just the platform, your obligations never went away.
Yeah, that's very good points, Vita. And our requirements really don't change. The CPT codes, trademark of the AMA, those don't change just because you're doing it through telehealth. You can't skirt those things. And I think we'll get into some of that in the submitted questions as we move on to the next phase. And again, here, just more links. And I believe all of these are also on the ArizOTA website, so that you can stay connected with the source documents. And I think that's a very big takeaway from this. If you remember to go to the source documents, don't take what Wade says. I've done my research, but like today, I almost made a mistake. Go to the source documents, understand them yourself, and that's what we're trying to provide to the ArizOTA membership on the ArizOTA website, so that you can make those informed choices, understand what it is you're actually billing for, and the services that you're providing.
And was that that last slide, Heidi, can you go back one? Does it have, that's the template letter we were talking about to send to CMS? Okay, and that also is going to be on, that's also going to be on our website. So this one of the things we want to do, especially, oh, by the way, I'm Sue Dahl-Papalizio. I'm the co-chair of the legislative committee. And I also have was a certified hand therapist for my whole career until I went into academia, and I've worked across every setting except peds and not a whole lot in psych specific. But I have a doctorate in behavioral health, and I teach at ASU's Doctor of Behavioral Health program, where our focus is on integrating behavioral health into primary care. And as an OT, I'm very active in increasing the visibility of OT and educating the community, the physicians, everybody in the healthcare, especially the primary care team, on what we can do in primary care. And telehealth is a big part of that. So it's one of the reasons I'm on this team. So one of the things we need to do to achieve the legislation, accomplishments, and increase, people's awareness, the decision makers' awareness of what we can do and why they should pay us, is to track what we do. We need to track our outcomes. So keep track of what you're doing. We're going to, it'd be great if we could take this opportunity in the midst of this crisis to show the world what we can do with telehealth. This is not an intervention. This is just a setting. It's just a different setting. It's a intervention delivery platform. And if we can show the world, we can do this, we are effective, we are cost effective, we are safe, track what you do. And I've listed here some of the things you can track, and we will put a template on the website as well for you to start, filling out. And we can keep track of these things, and we can start publishing on our outcomes. You want to track what platform you used. That can help us know and help your community, the other members of the OT community, know which ones are the most user-friendly, which ones you recommend. Track whether or not was it a telephone call? Was it asynchronous? Did you record? How many people were there? Just, what happened with the visit and the platform? What was diagnosis? What evaluations did you use that worked effectively with telehealth? What intervention did you use? Again, that was effective with telehealth. How many visits did it take to achieve your goals? Because think about, this changes the no-show world, right? So how many visits? Maybe I didn't put it on there. Were there any no-shows? Track these things. What were your outcomes? What CPT codes did you bill? What CPT codes were reimbursed? Who reimbursed and who didn't? So all of that information, just keep track of it for yourselves, and we can share as a community and get this information out into the world. Oh, good, we have, people are agreeing. There is a question I want to look at. I'm not sure if you mentioned anything about students in supervision. Direct supervision is required by rules and statutes. Yes, that one's for Vida. But rules and statutes doesn't say anything about ACOT states as long as there are audio and visual capabilities. Should I continue to hold field work for students, or can they participate in teletherapy? Let me get back to that one, because this is another one. And Wade is just saying CPT and HCPCS codes will vary by payer. Did you want to elaborate on that, Wade? Are you muted again? Stop muting yourself. Heidi, can you unmute Wade, please? He's a Zoom newbie. And Vita, did you want to address the question?
About students and supervision?
Yeah. Mm-hmm.
I would say that in this, the reason I keep referring to this crisis is when we go back to the legislature next spring and get our bill passed and signed into law, then that will trigger the Board of OT to then revise the Practice Act to address these unique features of telehealth. So right now, this is all very much up in the air, and it's all strictly limited to this pandemic. But if you can, there's nothing restricting you from having a student on your telehealth call also participating in the session for clinical education purposes. Just to point out for Medicare, if when we do get added as telehealth provider. Medicare does not reimburse for student services. So just be cognizant that when you document, the student was present for clinical education purposes and you were providing the therapy. So that same strict rule about students and Medicare still does apply.
And definitely document, and we'll talk about this when we get to the questions also, document that you were using telehealth. You don't want to run into a problem if you don't make that declaration in every note you write. Wade, did you want to talk a little bit about your CPT HCPCS comment?
Yeah, sure. So in our research, so regular Aetna had a short list, basically the e-visits that range from 5 to 10 minutes per week, 11 to 20 minutes per week, and 21 to 30 minutes per week. And a couple other codes we don't normally use, 98966, 98967. And so Blue Cross Blue Shield, however, said that it was our regular codes, same as in the clinic. So I'm looking at my other monitor. And Medicaid, I believe Access here has said the regular code, same as in clinic. Medicare, again, we've talked about, is just the e-visits. So there's a whole range depending on your payer mix that you need to understand on what they will or won't cover. So it's not a simple, easy answer.
And then Heidi, you can go on to the next slide. Okay, so do you want to pull up the questions? We've already addressed the questions on the chat. So there is one more. If you want to go ahead and pull those up, Heidi, then we can just kind of go through them, the ones that were sent in advance. Do you have that Excel sheet? Otherwise, Vita can share her screen. You want to share your screen, Vita?
Or do you want me just to read through them?
Sure, sure. And while you're pulling that up, Susan asked, did Blue Cross Blue Shield agree to pay in Arizona? What did he say about their codes? I think you had mentioned them, Wade.
Yeah, so Blue Cross Blue Shield on the website says that we're not covered, OTPT speech. However, the governor has issued an executive order stating that insurers must pay for telehealth same as in person. And so again, that's another example of yes but no. And so I think the governor will trump the website, no pun intended.
You know, it might be a good idea to even call them if you have a contract with them.
We were not successful in the last 2 days of getting a straight answer, but others may, your results may vary.
And keeping in mind that a lot of payers are also adjusting to a lot more changes than just OT and telehealth. And so it's taking them time to ramp up and change course. So, you know, some of these changes are happening quickly and you may just want to keep checking back to the website for more information. So the first, I just want to go back and point out that some of the codes, some of the standardized tests do have electronic versions for purchase. So something to keep in mind if you're administering standardized tests and need to send those questionnaires to the parents. And that's the legal response that I'm glad I was able to circle back on and say we shouldn't be violating other test owners' proprietary information. The question we have here is, how do we document assist levels for telehealth? Like what types of transfer levels, or how are we implementing assistance for our client or our patient? Who wants to take that question?
I can take that. That's something that we're working through. We've actually done telehealth visits here internally in the hospital. We've started those today with great success, and so that's been a lot of fun. and a challenge and scary all at the same time. But level of assist should be the same as in person. You're going to document, though, how you came to that conclusion, supporting your clinical judgment, your skilled service, and your training. So maybe it would say something like, based on the telepresenter is maybe a new term that I learned earlier this week, and that is the person helping the client on the other end. And so based on the telepresenter's report and the skilled assessment of this therapist, the level of assistance for whatever task is blank, min assist, mod assist, however you're going to grade your intervention. And also AOTA states the fact that telehealth was a setting should be indicated in the notes. So you're already reflecting that in the kickoff. Our intention here internally, and we're hoping to roll this out next week, is to include a standardized statement for all therapists that incorporates the things that we've talked about here on this call for the setting. And if there is a telepresenter, who is it? Can everybody hear everybody? In that case, we do a lot of pediatrics, and so we expect that often there's going to be a parent, grandparent, guardian, something like that present. Hope that helps.
Thank you, Wade. So the next question is, since this type of therapy requires more prep, research, and family support than an in-person visit with traditional materials, how are we billing for this time? And I think this is a good question for you, Wade.
I am all over this one. This is one of the things that I learned early on, and why, in fact, I became a rehab director. The CPT codes, as I mentioned earlier, do not change. There's very few CPT codes that include documentation time. Those that do say with report, and it's still rolled into that CPT code. So you can't add documentation time, prep time, to your CPT codes. Those are considered bundled into almost all CPT codes. If you're not sure what the true definition of the codes you're using are, I challenge you to please learn those, and Google can get you started. It might not be the final answer, wouldn't rely on it 100%, but it'll get you started and get you close. So no, and that's not a change.
And then piggybacking off of that one, there's a question in the chat, does Medicaid reimburse for OT telehealth? And it does. There is information on their website, and we will include a link to that in the resources, and it includes information about how to bill, which is really important because there are certain modifiers that you have to append. And the OT codes are in the set of telehealth codes. So Access is reimbursing right now for telehealth.
I see a question from Augusto about how are we going to quantify the number of cues, verbal cues using telehealth when you are guiding the session. I don't know if anybody has any experience with that. I don't, but I've used enough of these telehealth platforms to know that I am able to quantify just like I would in person. The only thing with this platform is I can't touch the patient. So I can't give a physical cue, but I can certainly track my verbal cues the same way I would as if I was in the clinic. Does anybody else have any insight into that or any thoughts on that? And this is a new animal for all of us. I don't know if anybody's done that yet.
I would agree with you, Sue. I think it would be in the same thing.
Yep, I agree.
You know, I also teach in person and I teach online, and I will tell you it's almost the exact same thing. And with telehealth, you know, I was thinking about this as an OT. I can't touch them, and I'm a certified, or I'm actually inactive now, but certified hand therapist for 20 years. And so I did a lot of soft tissue mobilization, joint mobilizations, and that sort of thing. I can't do that with telehealth, but I can certainly give instructions with active range of motion and strength, and I can count repetitions, and I can give feedback, and I can also, probably the most important thing, is do teach back. Have the patient, especially to maximize carryover and functional independence, have them demonstrate teach back and verbalize teach back, and I can absolutely document that.
Would you like me to address the question that looked like somebody was looking for clarification about what we are doing here? And so we are currently internally from basically our office to the patient room in doing some telehealth visits for acute inpatient rooms right now. We have that technology both here in the clinic via iPad on our secure network, as well as some specialized hardware in the patient room, as well as in some other rooms. So that's what we started today. The outpatient telehealth is what we are looking to roll out as early as next week. Have a few details to figure out yet, but related, but two separate interventions and security considerations.
And Augusto, read the chat because people are giving you feedback on what they have done. So you can see what other people are doing. Okay. Oh, and people are asking where you are. And I know you're in Northern Arizona.
You know what? I tell you, I am up in the mountains about 6,600 feet in the tall pines of Show Low, Arizona. Come on up in a few months, just saying.
Okay, so
Let's get to the, if we can just do the submitted questions first, and then I'll follow up with the questions on the chat box. So we can just get through the submitted questions first, and then the questions from the attendees.
Okay, so this is a question for Sue. Are there procedures for standardized assessments using telehealth?
So I actually looked into that because I don't know of any, and nobody I talked to knew of any. And I did find that AOTA has determined that some assessments, they've studied some assessments via telehealth, but not all of them. And there is an AOTA position paper on the AOTA website. I downloaded it, so I have it, or like I can get it. But I picked the most relevant section about specifically for assessments, and it said clinical reasoning guides the selection and application of appropriate ICT necessary to evaluate clients. So whatever ICT is what they're calling telehealth. I forgot what it stands for, but so you need to think about the most appropriate method to evaluate clients, their occupations, their client factors, performance skills and patterns, contexts and environments. Occupational therapists should consider the reliability and validity of specific assessment tools when administered remotely. Now, I don't know how many OT specific assessments. There are a few that have been validated for remote use. I know the PHQ-9 for depression has been validated with telephonic use, so that is, you can use remotely, but you would have to look, I would recommend you get that position paper, and you can also look at the actual assessments you want to use and find out if they've been validated. It may be too soon, but if it's valid for the condition, since there's not a lot of information out there, we're all having to demonstrate reasonable problem solving. I think it would be reasonable to try it. Does anybody else have any thoughts on that?
I agree with you. This kind of tracks back to your request to track. We are not doing this enough where we have extensive data, and so now is the time to collect the data.
Absolutely, and that's how we show something is valid. We do it, we compare it to other things that have been shown to be effective, and we determine validity. So the more data you guys can track, we can actually make something of this and show that we were reasonable later on to support this.
Does anybody else have any thoughts or questions or comments about that question? If you're muted, just wave.
Oh, they can unmute themselves now.
Okay.
So go ahead.
Diana, you can unmute yourself if you have a comment.
So I was wondering if there was a way that you guys could list as people, and especially here on our chat today, could, you know, list ones that they know have been used for telehealth. You know, so for example, I know the SPM has been and is approved and all that, but anyone who has other ones that could be listed, it would be really helpful to know.
We can look at that. I think we can do that. There were some listed in that position paper. I don't have it in front of me, but we can certainly put those on the website, whatever, you know, because that's from AOTA.
Okay, thanks.
Good idea.
All right, thank you. So on to the next one. And I'm not sure who can answer this question, so I'll throw it out to the group. Since there is no cap on groups for OT students in Arizona schools, how should we proceed to cover large caseloads?
So I answered this and I asked Courtney to comment on it because I wasn't sure, you know, not doing peds, I wasn't sure I was understanding what she was talking about. Basically from a group perspective, if a patient is in their home, let me just read this real quick. Okay, basically I would treat it as if I was doing the group in person, and the size that would be appropriate for the intervention and the population, and just document that I was doing it via telehealth, because this is something that what I'm envisioning this question was about is the same therapy I would do. I think Courtney said you can still provide group therapy through teletherapy. And then somebody on the, Barbara said VMI used, it is sent to parent ahead of time. And I think that's it. There's a couple other questions I don't understand what Suzette is talking about. Does anybody have any other thoughts on this? I mean, you might understand the question better. I don't do peds, so I might be misunderstanding it. Some of us have over 50 students, so they can be
basing this also on some of the questions I'm seeing about privacy considerations for groups and children. I mean, obviously when, you know, the FERPA, which I had to look up what that stands for, Family Educational Rights and Privacy Act, is the applicable law for the educational environment. And it does require you to protect the privacy of your students. And all those students in a group, definitely easier to do that when you're controlling the environment in person, and it will be a little bit trickier to do that in the home. And I think that's where you have to work with the families, because if you have several children on a Zoom meeting and there's things happening in the home, anybody that's provided early intervention knows a lot of things happen in the home in the best of times, and that will ramp up during when everybody's been cramped up for months. So, you know, getting that informed consent from the parent and finding out, working with them to see if maybe there's a private place to work. I think you're really going to have to evaluate some students you're going to be able to have groups with because the parents can set them up somewhere private, and they'll be good about controlling the environment. And there's going to be some students where you're just not going to be able to put them in a group. So use your judgment and work with the parent. There's a lot of people responding to this question and giving feedback and their thoughts. So be sure to look through the chat, because if this is one of your questions, they are giving some good resources. Yeah.
Yeah, I think one of the good things that I saw in the chat, and it's a good reminder, just like in the healthcare setting, you want to work with your employer, your school district, whomever it is that you're working with, because they may have additional resources and guidance that although public may be tough to find, and they can give you some direction as well to help with that. Sorry, I don't have much to do with school districts.
And I did see something about 50 students. I mean, I think just like, you know, your professional judgment to provide meaningful and appropriate therapy and to structure your groups in a way that the child will benefit from the services, that still applies in telehealth. So that's going to be difficult with larger groups. So think about, you know, if the children, you know, would they benefit from a larger group, or who could benefit from being in a larger group? I think 50 would be difficult. I don't know that I would go above 6. I always had a hard time managing 6 children in person, so going above that would be tough. So just remember, even though we're in a pandemic, all of your state practice obligations under your license, those were not waived in any way. Those all still very much apply, even to telehealth. And then I did see that someone said that the district said they could still do groups if the parents consent. And that's why we made the consent template a Word document. So you can customize this for whatever your needs are. If if that's what your employer's policy requires, make sure you add that in some fashion to your consent. So going on to the next one, sounds very similar of the pre-submitted questions. So there's no cap on groups in schools. How should we proceed to cover large caseloads? I think we have talked about that, using your best judgment, probably not overloading your groups, also being very flexible. We're OT, so we're good at being flexible. I think the biggest thing to remember is when you do this for the first time, it's probably going to feel messy and awkward, and probably not, you're not going to feel like you did a great job at it, but you're going to get better, and you're going to develop strategies for making this really work well. So I think it's just being patient, and then also sharing those out, getting on the our Facebook group, which Ashley will talk about, and sharing out those ideas. We're all a community here, so we can all work together to make this work. I talked about copyright. There's a question, is the coaching model appropriate for lower functioning students? Does anybody want to answer that one? I can jump in here and say that I have worked with children that were, fairly severely disabled. And I didn't always work with them alone. There was a parent there. And that's really, if you think about it, that's what, as OTs, we should really be educating the caregivers and the parents. That's the most beneficial service anyway. So I think that you have to use your best judgment, but you probably are going to want to incorporate parents that have availability, understanding that everybody's home and the house is probably going to be in chaos. But is the parent available to be there for this coaching? And I consider this kind of a dream, because when I worked in schools, I always wished that I could get the parents to come in and sit in on my session and do more coaching. So use this opportunity to educate the parent on the techniques they can use to carry over your intervention. We have another question. Can we coordinate with DDD to support our low-level students in the homes under school programs, since it's the same funding source? For example, letters to support equipment needs or modifications when they do not already have in-home providers. Does anybody want to jump in there? I mean, for me, having, worked in the schools and early intervention, I would say that the telehealth is not a service method. It's just another way to deliver services. So all those things that we did outside of our intervention would still apply. So, working with DDD to make sure that equipment needs are being met would still be very much appropriate. Here's another question. This one's for Wade. I would like clarification from the board itself that we're allowed to engage in the practice of teletherapy, because right now we're granted under an executive order, but the board, the governing body, has not ruled on this issue.
Yeah, so only in the context of this emergency, as we said before, but the state board website, when I checked it on the 30th, did have a statement right at the top of the page that clarified that now, after the executive orders, OTs are able to provide telehealth services. And they later clarified that was also there on the 30th when I checked it, that this applied to OT assistants as well for telehealth. So I'm going to defer that one to the Arizona Board of Occupational Therapy Examiners for the final statement, but that was what I found the other day when I checked.
And then Wade, this one is also for you. The executive order does not specify assistance for OT, PT, or speech. Can the board clarify this for our employers?
Yeah, again, I'm going to defer to the board website, but it did say that it included assistants as licensed occupational therapy practitioners.
Thank you.
And again, that link to the board website is on the ArizOTA website as well. And again, back to that source document statement from earlier, access those source documents. It's that way, don't take my word. Don't just read something, because the internet, everything is true on the internet, but that's a pretty good one. The state board website is a pretty good resource for you in really delving into what you were held accountable for.
So I can take the next one. Can OTs do telehealth evaluations? This is very payer specific. A payer plan that I happen to know of is United Healthcare. When I got this question, I looked at their policy, and it does identify the complexity codes. And as Wade said, these CPT codes for not Medicare e-visits, which is not telehealth, but for those commercial payers or Medicaid, those CPT codes that we use every day still apply in telehealth. And what changes them for the payer is appending the GT modifier or some other type of indicator like a 95 modifier. So if you look on Access's website, there's an Excel spreadsheet of the codes that are reimbursable under telehealth, and the OT complexity codes are on there. If you don't see those complexity codes, you may not be paying for the assessments. Pre-COVID-19 pandemic, the states that did have telehealth did have requirements to have one initial in-person visit. So some of them may still be taking that approach. So check those codes. I've called a lot of commercial plans. These are customer support people. They don't know those plans inside and out. And I've asked questions and then tried back 10 minutes later and got a different answer. Don't rely on those people to answer your questions. Get those documents. You want the website, their PDFs of their policies, and those Excel spreadsheets with those codes to confirm that you're going to be reimbursed. Just jumping ahead, I think we've answered a lot of these pre-submitted ones already in the presentation. So Benji, do you want to go to the chat, Benji or Sue?
Let's see. There doesn't look like there are more. Sarah, God bless you, Sarah. You listed the evaluations. I think those are the ones from the position paper, right? I recognize them. Should education with setup of materials be billed under self-care? I don't think you can bill for setup. I might not be understanding the question, Jamie, but that's kind of like documentation. Unless you're doing setup with the patient, and that is part of the treatment. I would not bill for it myself. But if I was having, if I was working on a functional task and I was having the patient, maybe it was somebody with cognitive issues, and I was having them find the things they needed and set up the activity. If I was having them like make a bowl of cereal or a peanut butter and jelly sandwich, and they had to go remember, state where the item was kept in the cabinet and go get it and bring it and set it on the table and then double check that they had everything, I would include it in that as part of the treatment. Otherwise, I personally would not do it. Does anybody else have any?
No, I totally agree.
Yeah, let me read the definition again. Don't mean to beat this horse, but it's an advantage I have sometimes to have quick access. But here's the definition of 97535, which we often call ADLs, but this is what it says. Self-care home management training, e.g. activities of daily living, ADL, and compensatory training, meal preparation, safety procedures, and instructions in use of assistive technology devices / adaptive equipment. Direct one-on-one contact each 15 minutes. So the direct one-on-one contact is really the key in what Sue's illustration was. If that setup and prep is done by the client with you, or they're cueing you through, or it's therapeutic for them, then it's included. If it is separate before the session, I think it's pretty hard to support that you've met the understanding of that CPT code.
I think a good way to look at this, and we keep going back to this is not an intervention, it is a setting. If you would not bill for this in your setting, you can't bill for it in the patient's home, right? If you wouldn't, I mean, just think of it that way. Again, this is just a delivery platform, a setting. The rules, because the rest of the world is looking at it for really reimbursement purposes and legislation for safety of the patient and everything, they kind of treat it like it's a different animal. But for all intents and purposes, for us as practitioners, all of the rules that apply to us within our licensure, within our role expectation and our scope of practice don't change at all. The HIPAA regulations, the FERPA regulations, if you're with kids, all that stuff, it's the same as if you were in the clinic. You just can't touch them.
I agree. Ivan asked on the chat if OTs can co-treat, and that's kind of ties into what Sue was saying. If you can co-treat in the clinic and the payer, check your payer policies. Co-treating, is make sure you're reading those CPT codes and fitting your service into those codes, because if you don't, that's called fraud, and that can get you in a lot of trouble. But as long as the payer pays for that and the services you provide meet that code definition, then certainly you can co-treat. And it's medically necessary, which will be in the policy, and that's huge, is to make sure that the purpose of that co-treatment is medical necessity. And I would even say, make sure you document that.
So there is, we just need to leave a few minutes at the end. So we probably have about 5 more minutes. It looks like there was a question on coaching, using coaching for students in home under the IEP, when I hadn't had that included when I was in the classroom. I had to have caregiver education identified as part of my new telehealth plan and treatment, which is why an IEP addendum or some other form that the caregiver signs may be necessary. All right, I think that might be an answer to one of the other questions. Then there was one more at the end. Do you guys want to look at that one from C.A. Hartman? Do we need to alter OT supports? It's a PEDS question, so anybody with PEDS background. Based on what specially designed instruction is being provided during this time in the school setting. According to Arizona TAS, OT supports are written to support SDI. If SDI is decreasing at this time, then I would think that OT supports would be reduced as well. There has been little guidance on how we should continue. Follow the IEP or reduce based on what is being provided. I don't know what all those acronyms are.
Yeah, and unfortunately, I don't know what SDI is.
You
But-
guys can unmute your microphones too if anybody wants to talk about this.
So I can jump in. I'm a school-based OT. So essentially, we are required to provide OT services as a related service as long as students are receiving instruction in the general education setting. So for instance, in my district for the past several weeks, our students in Gen Ed have not been receiving services. They've been receiving packets, which does not constitute as receiving any kind of specialized, I guess, just general education. So when our district moves to providing specially designed instruction, and the students will be receiving special education services, at that point, we are required to provide OT services to the best of our ability. According to IDEA, we are supposed to match our services to the best of our ability to the IEPs. However, we all know that that's very difficult when we carry high caseloads. We typically group kids together, especially when we are doing so much consultation. And if we're consulting with the special education teacher as a part of the IEP, and the teacher is kind of out of the equation or are not necessarily involved the same way. So I'm personally, I'm just going to be using my personal clinical judgment moving forward, how to best meet the needs of the students. I want to best meet their IEPs to the best of everyone's ability, but we know that can be difficult. There is the option to do compensatory time in the fall if that's an option, and it's all a team decision. So everything is highly individualized. We do our very best to match the IEP, but we know that's not realistic given the current crisis. So we do the best we can. I hope I answered that question okay.
No, I think you did a great job. That's the key word, is use your clinical judgment always, and do the best that we can. I mean, this is unprecedented times, and we're all just trying to still go out there and provide these necessary services to clients, and nobody's going to fault you for that.
I think we have time for one more. Can you address billing and documentation for telephone-only telehealth? This is probably for Wade. I have a lot of patients on the Navajo reservation and video is not feasible. This is why we have to have telephones specified. Note to self for next go round with the bill.
Yeah, so, and so do we. We serve both the Navajo and the Apache nations here, and so that's a real issue for us. It's a pretty tough one to work around. Our research so far says it's very dependent on the payer. The most consistent is for synchronous, that is live audio video interaction. Some may cover telephone only. Others may not. Again, so it may really depend on the payer. If you're working with a tribal access plan, that information may be more readily available, and that could be, if you sort that one out, it could guide you for at least a significant number of your patients. One of the things, just to follow up on an earlier question about, what do we document, how do we document, and we've thrown out terms like skilled service and clinical judgment and those kind of things. One of the things that we can upload, it's a Medicare resource, but it's a really good guide for therapist documentation. And it's outpatient rehabilitation therapy services complying with documentation requirements, and we can get that uploaded as a resource for you. It's one that I share with my staff every year or two, or as I get new employees and stuff like that, and it just kind of lays out everything. Some of it may not apply depending on your setting, but I think it's a pretty good primer for what is good documentation.
No, I totally agree, Wade. I know it says Medicare Part B outpatient, but it's really not specific to outpatient. It applies across the board. And these Medicare Learning Network articles are really a gem. They're a good source document to make sure that you're relying on the right information. You just really can't go wrong by using this to improve your documentation, even when the crisis is over. So thank you.
So we're going to save this chat and try and capture any questions we didn't answer, add them to our spreadsheet and work on answering them. And we can put that information on the website or, you know, address it in another town hall. We'll figure this out moving forward. But I know Heidi wanted us to leave about 3 minutes at the end. So I think we're out of time for this right now. Heidi, do you or Evelyn want to take over?
I think what we have left, Ashley, is the resources, right?
Yes, so can we go back one slide, just really quick? I know we've touched a lot on the fact that all these resources are going to be on our website. We've got it kind of divided into two categories. The first is going to be just general updates regarding practice of OT during the pandemic. The second site that's listed is specific to telehealth. So that's also on our website. And then the last thing that's listed is the AOTA information hub, and that's been very helpful, I know for me. They've got a lot of stuff, and as with all of these pages, we're just updating them all the time. So what you see now might be different tomorrow or even in a few hours. So just check back often because things are so fluid. But these are great resources for you to consult and share with those that you might work with or go to school with. And then the next
throw out there, I hope this was really helpful for you guys and we can use more hands on deck.
Yes, that is very true and kind of leads into the next or the final slide. So it's been really great to see the power of all of us unifying in the state, whether or not you're an ArizOTA member. So many people have come together to help get the executive order and to help each other figure out what we're supposed to do in this time. So we just want to stay connected because there is power in that unity and strength in that unity. So we've created a new Facebook group, and you may or may not already have been invited or be a member, but we envision this as a place that you can go to ask questions. So maybe you have a question that came up tonight that didn't get answered, and maybe it's because we don't know the answer to it. Share it with the people, with your peers on this group, and share ideas. Share what you're doing that worked or didn't work, and let's learn from each other's successes and failures. So there's a link right there to that Facebook group. Also, if you are not already signed up for our text message updates, we've been using those. It's been very helpful, at least the feedback that we've gotten. Because things are moving so quickly, we've used it to keep people updated with you know, the executive order, with needing to reach out to the governor. And so we will keep you updated. We don't do this normally. We only do like normally one text a month, but because things are moving so fast, we're trying to keep you guys updated, but just text ArizOTA to 27,000. And then finally, as was said, we are a volunteer organization. We need your voice, we need your support. And a lot of what we've talked about tonight is legislation, and the dues that we pay for ArizOTA help us hire a lobbyist that helps us to be able to make this legislation come to pass. And I think maybe in the past, at least for me, I was like, oh, you know, legislation, that I don't really have to deal with that. But now it's right in front of us, and we're seeing how important it is. So please consider joining. And we would like to offer you a $5 off coupon. If you can join or renew your membership, we'd love to have you. You enter that code at checkout. If you've joined within the past few weeks or month and you want to take advantage of this offer, we totally want to give it to you too. So just email office@arizota.org and let Emily know. She's our administrative assistant. Let her know, hey, I registered to be a member. I want to take advantage of that offer. And finally, there are our social media profiles. Again, let's stay connected. Let's help each other out during this time.
And I just want to thank everybody for attending, and I hope it was helpful. And a big thanks to all the presenters who helped preparing this and answer all the questions. And just remember, we will continue on the webpage, and Ashley is very fast and very efficient in posting things. So if you have more questions, we'll continue to post and answer them, and all the updates that happens every day when it comes to legislation and this crisis. I hope you have a good evening and you stay healthy, and thank you, everybody.
Thank you.
Thank you.